Good evening, everyone. It is 7 o'clock, so we would like to begin to welcome everyone to Wednesday Wellness. Wednesday Wellness is a free live educational series by Trinity Health, and we are thrilled to have you with us as we dive into this important topic of breast cancer screenings and therapy. Before we get started, we do have a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during this presentation, we ask that you please use the Q&A feature. This is located near the bottom of your screen in that little toolbar, and our presenter will address your questions at the end of the presentation. Lastly, this webinar is being recorded, and we are going to be sharing that link via email in the next couple of days, along with some great resources. And without further ado, it is my pleasure to introduce tonight's presenter, fellowship-trained breast surgeon, Dr. Jamie Caughran.
Thanks everybody for joining. I'm going to dive right in and start talking about breast screening. I think it's very confusing because we've had so many different guidelines come out over time. Do we start at age 35 with a baseline? Do we go at 40 every other year, every year? There's so many different guidelines. The United States Preventative Service Task Force has done a great job of disrupting a lot of the recommendations from the American Cancer Society and the American College of Radiology. These are some of the different societies that try to issue guidelines that we can all follow. I think this highlights some of the confusion of where we start. Do we start at 40? Do we start at 45? Do we go every 2 years, every year, every other year? It's confusing for providers, it's confusing for patients and what we should do. Other things that we talk about are self-breast exams, which is abbreviated SBE, and clinical breast exams. I'm a big believer in knowing your normal. So getting to know your body is, I think, a good thing. Mammograms are a great test, but they're not a perfect test. So I always encourage women to check their breasts the week after their period. But again, you can see by the different guidelines of the American College of Obstetrics and Gynecology or family practice, should we even teach people how to do self-breast exams? All this kind of adds to the confusion on what we should do for screening for breast cancer. American Cancer Society says that women between the age of 40 and 44 have the option to start every year. Between 45 and 54, they should go every year. And after 55, they can go every other year or continue to go annually. I think one thing to highlight is if a woman wants to continue annual screening, even if a particular guideline says every other year, usually their insurance will cover that. When do we stop screening? That's another question I get as women age. And what we tell people is that as long as we anticipate someone being around 10 years, we will continue to screen them well into their 70s, 80s, and beyond. Because not all 70 and 75 and 80 are created equal. Some women have a lot of health problems in their 60s, for example, and I see really healthy 90-year-olds. So we do continue to screen as long as we anticipate someone to be around 10 years. So one of the downsides of mammography is cost. We have limited resources in this country, and estimates that I found, estimate the cost of screening mammography around $11 billion per year, with only 37% of women receiving an annual mammogram. So even though a lot of people are supposed to be getting mammograms every year, that doesn't happen in real life. This, rounds out to about $7,000 to $13,000 per woman per lifetime. And depending on the different guidelines that you follow for screening mammography, that could cost anywhere from $30 billion to $8 billion a year. So we have to take this kind of in perspective of all of the healthcare costs that we have in this country. Just out of curiosity, I had looked up what other therapies cost. So treating hypertension, for example, is about 131 to over $200 billion per year. And then high cholesterol is about $54 billion per year. So those also, equivalent into life saved as well. But it's just kind of interesting to put in perspective how much money this actually is. Another concern I frequently address in my office is the concern of radiation in mammography. So typical mammogram has a very low amount of absolute radiation, so 0.4 millisieverts. Normally in the United States, we're exposed to about three of those per year just from living in the country and being in our natural environment. So the amount of radiation in a mammogram is equivalent to just being around your current environment for about 7 weeks, or similar to taking an airplane flight. So it's a very tiny amount of radiation that we don't think has any significant impact on our health. One thing that I always like to highlight anytime I give a talk like this is the deficiencies in mammogram compliance. So this was a really good study that was done at Mass General. They had over 254,000 people or women. And in a 10-year period, only 6% of those women received a mammogram every single year. So we all think we're going once a year, but life happens, and only 6% actually hit every single year in a 10-year period. And the mean number of mammograms was 5. So this was prior to all of the guidelines that were issued, making screening more confusing. So when the recommendation was an annual screen, the average that we were doing at best was about 5 in a 10-year period. And obviously, women who are underserved or underinsured and non-English speaking women were more at risk as far as compliance with mammography. In Michigan, we see similar numbers, 60 to 64% over the age of 40 reporting to get a mammogram within the last year. That is more challenging in women without insurance. There are a lot of resources that we have that will cover an annual screening mammogram. As long as you are over 40, you don't need a doctor's order if it's been more than 365 days from your last mammogram. So let's talk about how women actually come to my office who do have breast cancer and how are they presenting. This was a study that we did in the state of Michigan. It was a Blue Cross Blue Shield Michigan Quality Initiative, and we had this huge group of hospital systems that pooled together all of our breast cancer data, and then we started to look at that and try to do quality work collaboratively throughout the state, which was it was a great project. In this particular study, we had 30,000 patients that we could track data on, and then we split them into how they showed up with their breast cancer. One of the first things we'll talk about more later is invasive breast cancer versus non-invasive breast cancer, or DCIS. DCIS are usually microscopic findings, and that's something that we almost exclusively diagnose on a mammogram. Invasive cancer was about 80% of our patients in that population. In women under the age of 50, there were about 22%, and the other 78% was over 50. And you can still see in a screened population, we still have a significant number of palpation-detected breast cancers. Mammograms were better represented in the women over age 50, but in the women under age 50, palpation-detected tumors were actually more common. So that's why I still think it's very important to encourage self-breast exams. Some of the conclusions of the study that we did, regardless of all the changes with all the screening recommendations, 22% of the cancers were in women under the age of 50, and they more often, like we just talked about, presented with palpable tumors. Those women had a higher stage of presentation, they had more aggressive biology, they required more aggressive surgery and chemotherapy. So when we're making decisions on who to screen and when, I think it's important to highlight that all of these things come together and impact patients. So if we can find things when they're smaller, it's usually much simpler to treat them. Another thing that I get a lot of questions about are what are the risk factors? And a lot of women are like, well, I don't have it in my family, so therefore I really don't have to go get a mammogram. So these are the factors that are actually, we'll talk through what are real risks and not real risks. So real risks, the number one is female sex, I think. Yep. So almost all breast cancers, 99% or so, occur in women. Men have breast cancers more often with a BRCA2 mutation, which is one of our genetic mutations. Men do have breast tissue. They can get breast cancer, but the number one risk factor are number one, being a woman, and two, getting older. And you can just kind of pop these all up. Yep. So in age, as we get older, if you feel something, you're more likely to have a cancer than when you're younger. So you can kind of see in your 40s, a 1 in 1,000 risk versus in your 60s, a 3 in 1,000 risk. Women with a personal history of breast cancer are a slightly higher risk of future breast cancers. One of the ones that are often confusing is atypical pathology. So if you've had a needle biopsy that showed atypical ductal hyperplasia or atypical lobular hyperplasia, it's a very specific word saying atypia. That is a significant risk factor in developing future breast cancers. Receiving radiation to your chest wall is, so let's say you had a type of lymphoma where they gave you radiation to the center part of your chest. That is a significant risk factor. And we were talking about the radiation doses in total. This would be a much, much higher dose than the tiny doses we were talking about with a mammogram. And then family history is the last one. And you can just pop all these up again. That would be great. Thank you. So these are the ones that people like to talk about as risk factors, but usually have not a very significant impact on risk. So hormone replacement therapy, it's a tiny absolute increased risk. It's depending on if you do what we call a relative risk, comparing the one number to another, an absolute risk. But in total, there were 8 different sets of cancer versus non-cancer out of 10,000 patients. So it's a minor risk factor. The use of alcohol. So if someone's a heavy or regular drinker, if they're not getting enough folate, that will increase their risk. Women all the time in my office talked about lactation. Well, I breastfed all my babies. I don't understand. Really, lactation is protective if you're not ovulating. So a 4% reduction per year. Another study I had read, it said you have to breastfeed for about 10 years to have it be protective. So it's less than we would hope. Being older when you have your first child, and then a early menarche or a late menopause, it's just more exposure to cyclical estrogen in your lifetime. And then birth control pills are a very minor risk factor, and that usually goes away once you stop them. And obesity is another one. Thanks. Breast density we do talk about. It's harder to see things with dense breasts on mammograms, but the absolute increase in risk is pretty modest. So we talked about women and getting older being our biggest risk factors, and you can kind of see the rates of breast cancer over decades. So when you're in your 30s and 40s, those numbers are pretty low, and as we age, those numbers get higher because it's just more exposure to the environment and more cell divisions in our body. This, I think, is just a good slide, and you can review it probably if anyone chooses to go back and look at this. But it talks about the absolute risk of getting breast cancer depending on what decade of life you're in. We always talk about a 1 in 8 risk of breast cancer, but that's when we're at age 85. So in your 40s, your risk is 1 in 65, for example. And then the risk of dying from breast cancer, luckily, is relatively low compared to those risks of getting breast cancer. This is another slide just kind of demonstrating the impact of screening. So if you look at the bottom, it talks about women that aren't screened, and then at the far right-hand side, it would be the women that are receiving annual screening between the ages of 40 and 74. We want to see bigger light blue, which is stage 0 breast cancer, and bigger stage 1 or orange bars there. So obviously it kind of follows that the less we screen people, the more advanced stage of disease they will have at presentation. A website I use all the time in my practice is asktome.org. So this is developed in Mass General by Dr. Kevin Hughes. And what he has done is he's taken all of the genetic mutations that we know about and will calculate based on how old you are right now and if you've had other previous cancers. If you have one of these genetic mutations, what are your risks of cancer? And so we see people with genetic syndromes in our practice, and we manage them sometimes surgically with prophylactic mastectomies. But it's interesting to take, so I put up one example on the left is a CHEK2 mutation. It's a moderate risk mutation. And you can see the absolute risk of cancer compared to the average population is higher, but it's still relatively low in the 40s and 50s. We consider someone high risk once we hit about a 20% risk level. Compared that to the bottom right, where you've got a BRCA1 mutation, which is a very high risk mutation, those numbers are significantly higher. So when we're trying to decide what interventions and what kind of screening do we want to do for somebody with genetic risk, this is a great resource to look at. I always like to kind of throw this in there for perspective. And unfortunately, I couldn't find an updated slide. This one's like really old, but I think it's a very good visual. Looking at the rates of heart disease compared to the other causes of death in women in the United States, what a lot of the graphs do, they will just put cancer as one big lump disease, and that will add lung cancer and breast cancer together. Lung cancer and breast cancer are broken out here separately, but you can see heart disease is the #1 killer of women. And so I never want women to lose sight of that as we're talking about their future risks. Okay, let's talk about breast imaging. Something I say that often gets confused is the difference between a screening mammogram and a diagnostic mammogram. So let's say, for example, a woman is at home, she feels a mass in her breast, and she's like, oh, well, I've got a mammogram scheduled in 3 weeks. That's no problem. I'll just show up and do my mammogram. A screening mammogram, you come in and you're supposed to be completely asymptomatic. We don't know that you're feeling something. We don't know that there's a problem. A diagnostic mammogram is you come in and say, hey, I'm feeling something. I need to get this one particular spot checked out. The technician will do additional views. They will often do an ultrasound. We'll work it up while you're there that day. It's a much different experience. We're just getting your 2 views of each breast and going home. The difference for this is that screening mammograms are the once a year covered by insurance plans. Diagnostic require doctor's orders, and there's usually a copay for those. So people like to get their results the same day, but unfortunately, there's a downside to that, and it usually, costs more for your insurance to have a diagnostic exam. But if you are feeling something, we certainly want to know that. So please tell your technician and let your providers know prior to arriving so we can do the right workup for you. Breast density is a hot topic. Most states now have mandatory reporting for breast density. On the left, you can see pretty much a whole fatty replaced breast. And on the right-hand side, the level D density, there's a lot of white tissue. Breast cancer shows up as white on a mammogram, and dense breast tissue is how much white you have compared to darker, fattier tissue. So for the most part, in urban areas, you're going to receive all 3D mammography. All of our systems at Trinity Health are 3D at this point, which is great. Um, but you will get a notification in the mail if you have level C or D breast density. I will go on to say that about half of the population does have dense breasts. So that doesn't mean you qualify for additional screening. It's more just an awareness of it. And that's why I think self-breast exams are still very important. I also get a lot of questions in my office about ultrasounds. Can I get an ultrasound instead of a mammogram? I don't want the radiation from a mammogram. Why don't you just ultrasound me? Ultrasound is very technician dependent, and it's very good for troubleshooting a particular area, especially if we have a focal area of pain or something that we're feeling. It will let us know the characteristics of the lesion, what the borders of it look like. Does it look solid or does it look like it's fluid filled? And based on those criteria, we can decide who needs a biopsy or not. So sometimes what somebody's feeling is just normal glandular tissue, and there's absolutely nothing wrong with that area. But women can have little glands or islands of glandular tissue which feel like a lump, but usually are nothing if we check them out and it's just normal glandular tissue, which is great. It's hard to screen an entire breast accurately with ultrasound, and that's why that technology is not used for screening. It's really better for troubleshooting. MRIs is a very sensitive tool for screening the breast. There are traditional MRIs, which are run through your insurance. They will be approved if you have more than a 20% lifetime risk of breast cancer, or if you see someone like myself or my partner who are working up a complex problem and we go through certain diagnostic criteria to get you approved for a breast MRI. We had done a clinical trial at Trinity Health looking at digital mammography 3D compared with an abbreviated MRI. And we've started offering cash pay MRIs to patients, so you don't have to hit that high risk level. The cost is now $500, which is much less than the traditional breast MRIs. They are not yet covered by insurance, and that's why we have a cash pay option. I thought initially that we would be using these more in women who are worried well that aren't high risk but want to have additional supplemental screening beyond their mammogram. And what I'm actually seeing is we have a lot of patients that have very high out-of-pocket costs, and it's actually more affordable for them, even if they are high risk, to have a cash pay MRI. So I think we will see more MRI screening in an abbreviated or cash pay option in the future. Most MRIs, I will mention, if they're for screening, we try to time them with your menstrual cycle because they're more accurate if we do them the week after your period. This is just a picture of what a breast MRI looks like. A lot of people are worried about being claustrophobic. You actually look down through the table towards the floor. So I'd say most of my patients do pretty well with them. They're not fun. It takes about 45 minutes. You need an IV, but there's no compression and there's no radiation from an MRI. This is a great picture of the power of MRI. On the left, you'll see a very dense breast that looks very normal in mammography. This is the choroidal MRI finding. MRIs, because they're contrasted, can subtract out all of the background noise, and you can see a very obvious cancer on the left-hand side there. The next patient is who probably won't project super well on your screen, but there are tiny little calcifications on this mammogram. This is from a patient who is actually a personal friend of mine, and we ordered an MRI on her, and you can show the next slide, which showed she had a much larger mass than what we could see on mammography. So MRI gives us very great pictures and is often very helpful. So we've touched on abbreviated MRIs. If somebody's really interested in looking at what else is out there for breast imaging options, molecular breast imaging is interesting technology. There's a much more significant radiation exposure with this. It is a functional test, so because it's like a radioactive injection, there is more radiation, but it will light up areas that look abnormal. Go to the next slide. I included PET and PEMS. There are certain labeled tests that we can use specific tracers to look at the whole body or just the breast tissue in general. They are very rarely used for screening breast tissue. One of the interesting technologies that we're looking into is contrast enhanced mammography. So it's similar to a mammogram in experience, but you are injected through an IV, so you'd have to have an IV started. And we're hoping it will perform in a similar way as an MRI without having to go through the MRI machine and hold still for 45 minutes. If you go to the next slide, I think we've got a picture of a contrast enhanced mammogram. So on the left, you've got a standard mammogram view, and this is a representative picture of a contrast enhanced image. So something to keep your eye on in the future. I'm going to dive into breast cancer a little bit and update you on what's new. There's lots of changes in the breast cancer world. I always show this in my talks because I think it's helpful to kind of frame what we're talking about. Breast cancers, when we call them invasive, the cancer cells push through the membrane of the cell into the tissue around it. Compared that, we mentioned DCIS or the non-invasive breast cancer that's kind of in the middle part of the slide. That's where the cancer cells are contained within the duct. So everything we talk about biologically stems from if it's invasive or non-invasive. And people think, and it's very common in my office, that it's like one duct that has cancer and it's just broken through in one spot. I wish it was that simple. When our pathologists read these slides, there's hundreds of these ducts on these slides. So it's a region, it's not necessarily a specific duct that's involved. Okay, next. The picture on the right shows us the different biologic types of breast cancer as we group them clinically. So we have estrogen-fed breast cancers that are HER2 negative. We have HER2 positive breast cancers, and we have what we call triple negative or basal type breast cancers. If you can just hit the other animations on there. Yep. So, yep, that's okay. We can roll with that. Oh, all right. Surgery and radiation go to fix the local problem, but what really matters is, are these cancer cells going to spread? So like I was talking about, the triple negative breast cancers and the HER2 positive breast cancers are going to require more therapy because they're more aggressive. So as long as they're about 5 millimeters in size or larger, we are going to treat those with some type of chemotherapy because they're much more likely to spread throughout the body. So the analogy I use in my office all the time is dandelion. My job as a surgeon is to take the dandelion out with the roots, and radiation kind of puts weed killer in that spot. But what matters is how likely is that dandelion to send off a seed to the rest of the yard. So some high risk dandelions, even if they're small, we have to treat the whole body with chemotherapy to make sure that these cancers don't return. So we have slower growing breast cancers, like we mentioned, estrogen fed, HER2 negative. We also call these luminal A or B type tumors. What we're seeing now is we're using genomic profiling. So one that was commonly used is called an oncotype test, where we test the tumor to see if they would benefit from chemotherapy or if the tumors have any specific aggressive genes associated with them that would warrant chemotherapy. And we're using these predictors in people who have larger tumors and sometimes lymph node positive disease. Traditionally, they would normally get chemotherapy, but what we're doing is really working on the biology of the cancer to see if the chemotherapy would even work for these if there are very slow growing tumors. And the counter of that are the triple negatives and the HER2 positive, like I mentioned earlier, will most likely receive some type of chemotherapy if they're more than 5 millimeters in size. Okay, you can keep coming. So a lot of what we do in our office is look at whatever the breast cancer scenario is for the particular patient, figure out how to remove that from the breast safely and have a good cosmetic outcome at the end. We often do procedures called oncoplastic surgeries where the oncologic surgeon will take out the tumor, and we have a plastic surgeon we work with that will do a breast reduction, for example, at the same time. It's a great option. We're able now to shrink tumors down prior to removing them. We have a lot of options for testing the lymph nodes, and we'll talk about that in a little bit. Historically, if you had any kind of lymph node involvement, it would require taking all the lymph nodes out underneath the arm, and that has a much more significant side effects. We now are able to retest some of those lymph nodes and spare a lot of women additional lymph node surgery. We're using more needle biopsies instead of excisional biopsies. That's been standard of care for probably 20 years. And then, in the high-risk patients, we're doing MRIs and using prophylactic surgery, especially in patients with genetic mutations to prevent them from ever getting breast cancer. This is a great trial that we had open at Trinity Health here in town, looking at DCIS, or slow-growing non-invasive breast cancers, randomizing these patients to endocrine therapy or an estrogen blocking medication versus standard therapy, which would be surgery with or without radiation and estrogen blocking medications. And as of March of 2025, we've enrolled almost 1,000 patients on the study. The data is currently maturing. But at this point, with at least 2 years of follow-up, we were demonstrating similar rates of this DCIS that we're managing non-operatively as stopping from becoming invasive. So as long as we're keeping things, so we're not operating on half of these women in these trials, we're watching them every 6 months with mammogram. And so far, everything looks pretty encouraging that we are probably going to have in the future options for non-surgical management for low-risk, slow-growing DCIS. Choosing wisely guidelines, these came out in 2016. The big one I highlighted here is not doing sentinel node biopsies or not surgically removing lymph nodes in women who have low-risk tumors. So women that have estrogen-fed tumors that are over the age of 70, having a lumpectomy and radiation, we don't check their lymph nodes anymore surgically because there's no benefit in doing that. And if you can just go to the next slide. We are able to tag things and mark things much differently than we used to in the past. If any women that are on this had had a wire-guided biopsy, excisional biopsy, or lumpectomy, we used to put wires into the breast that would hang out of the breast, and then we would take those out in surgery the same day. We're now able to find these lesions and put in these special marking tags so we can find them in surgery. We will mark them and then sometimes treat them with chemotherapy for about 5 months, and then we can go back and resect that area in the future. The images on the right are the particular system that we use here at Trinity Health. It's called a mag seed. They can stay in the breast for months or years. There's no radiation associated with them, and then we have special probes that will detect them in surgery. There are many products available to mark these. I don't want to favor mag seed. I'm trying to be fair and not biased at all, but there's radioactive seeds and different type of tag receptors that we can put into the breast. They each have their own special pros and cons, but lots of things that we can do to do targeted surgery for women. We talked about sentinel node biopsies. We inject dyes into the breast. We find the lymph nodes that drain the breast, and then we remove them. You can just go ahead and go on. The Z11 trial was a huge trial for breast surgeons, and what this meant is women that were having lumpectomies with planned whole breast radiation who didn't have any palpable lymph nodes at the time of presentation. If they had 1 or 2 lymph nodes positive, half of the women were randomized to X-ray lymph node dissection, where we take out all the lymph nodes. The other half, we just did the sentinel node biopsies, and this had really remarkable results that there was no difference in recurrence or survival if we just did the 1 or 2 lymph nodes taken out and that was it. So it's downstaged how many women need a full X-ray lymph node dissection, to the point where I don't do many full lymph node dissections anymore with our different treatment options. So the Z11 trial was a huge one for breast surgeons. And again, this is just another representation of when this was published, that women are alive and disease-free at same rates, whether or not they had a lymph node dissection or not. Sentinel node biopsies after chemotherapy. So there's a lot of movement in this area too. Let's say a woman presents to my office. She has cancer in her lymph node. We sample that lymph node with a needle. We put a clip in it. We treat her with chemotherapy for 5 months, and then I can put one of my special tags in that lymph node, take it out, and retest it. And if those lymph nodes clear and are negative, I don't have to do a lymph node dissection on that woman. So there were many clinical trials that got us to this point, but that's now considered standard of care. It's called a restaging sentinel lymph node biopsy. And those seeds that we use have really made that a lot easier for us to do. Again, this is kind of the details of what we do. We use multiple tracers. We want to get at least 3 lymph nodes out. We make sure we get the clip node out, and we're getting great results from that. So this is the next phase of breast surgery, de-escalation. Can we avoid doing sentinel lymph node biopsies altogether? You go ahead. We're using X-ray ultrasound pretty routinely. I'm very fortunate to work with some outstanding breast imagers at Trinity Health in Grand Rapids. They will routinely scan my patient's underarm or axillary region when they come for a diagnostic workup if they are shooting up something or troubleshooting something that could be a solid mass that's a cancer. There are very specific criteria for looking at lymph nodes on X-ray ultrasound. It's a very accurate test to see if the lymph nodes look like they have cancer cells within them or not. And that's usually based on the thickness of the cortex of the lymph node. And if you look on the right, those images are kind of represented of lymph nodes that have a thickened cortex or an eccentrically thickened cortex. And as the lymph nodes get from kidney bean shape to more rounded in shape, that becomes a much more concerning prognostic finding. So if we're seeing round, plump lymph nodes like that, that's a bad sign that there's probably cancer in that lymph node. So where we're taking this is 2 clinical trials that have recently been published called the SOUND trial and the NCEMA trial. These are women that we are doing sentinel lymph node biopsies versus no sentinel lymph node biopsies on. 1,400 patients in the one trial, about 4,800 patients in the other. They are women who have T1 tumors in the one trial and up to T2, so anywhere under 5 centimeters in size. They have a pretty good age range of these patients and different types of receptors. So it's not just the super favorable, low risk, slow growing tumors. They do have more aggressive tumor subtypes within them. Go ahead to the next slide. So what we're seeing in the women that we're not, so we're using X-ray ultrasound instead of the sentinel lymph node biopsy. So we're avoiding taking lymph nodes out altogether. And what we're seeing are the results are the same. There was no improvement in outcome in the patients who had surgically staged lymph nodes compared to X-ray ultrasound. Okay, so the things that we're cautious about using this new data in is that the number of women that had very aggressive features of their tumor was small in the trial, so under 6%. In premenopausal women, we still rely on lymph node staging to determine who's going to require additional therapy, even in low risk tumors. So these are some of the bigger things that we look at in trying to adopt this. It's definitely a multidisciplinary decision and who we're going to omit sentinel lymph node biopsies on. You can go ahead and just go to the next slide, I think. So what follows from there, if we're not taking out lymph nodes, can we avoid surgery in people altogether in the breast tissue? So we've gone from X-ray lymph node dissection to sentinel lymph node biopsy to restaging sentinel lymph node biopsy to no sentinel lymph node biopsy and just using X-ray ultrasound. This is from our American Society of Breast Surgery meeting. Originally, we started with mastectomy of the breast and then breast conservation or breast conserving surgery where we do lumpectomies and radiation. Can we get to a place where we don't have to do breast surgery anymore and we can just manage things with needles and biology? So this is an example of a clinical trial that's currently enrolling. This one's at MD Anderson. They're taking the neoadjuvant chemotherapy population, so the women who have the aggressive tumor subtypes, the triple negatives and the HER2 positives. They're biopsying the area, putting clips in. They're receiving neoadjuvant chemotherapy for 5 months, and they're resampling the area with another needle biopsy. And when they go to do that second needle biopsy, they have to resect all of the area that was originally there with the clip that was there, and then they test that tissue from the needle biopsy. So it's very interesting. I'm not sure if I'll see in my lifetime omission of surgery, but with these people that are very good responders to neoadjuvant chemotherapy, if we can resample the area and prove there's no cancer cells, we might be able to avoid surgery in some patients in the future. we'll go ahead and talk about systemic therapy changes in the last few years. And again, I will preface this by saying I'm not a medical oncologist, but there are new drugs that are constantly coming out that keeps our jobs interesting and changing in the benefit of our patients for sure. So CDK4/6 inhibitors is a class of drugs that are used to augment estrogen resistance. So we use estrogen blockade to treat tumors that are fed off of estrogen. On the right is a list of 3 drugs that we use to do that. And we're adding these in with very good results long-term after therapy has been completed. So the 2 most commonly used drugs that are best proven are given for 2 to 3 years after their therapy is completed, in addition to the endocrine therapy or the estrogen blocking medications. They have some different side effects, but in general, it's helping women stay healthy longer. This is the biggest change, I would say, in my career that I've seen is the use of Keytruda, which is a trade name of a drug. Pembro is the abbreviated version that we use in medical therapy. This is a special drug that is used to augment triple negative response to chemotherapy. And the way that it works is that we have to give the drug prior to the tumor being removed. And it helps the immune system recognize those cancer cells while the tumor is still present in the breast. And then the drug is continued before surgery as well as after surgery. And you can go ahead and skip to the next slide. And this is just a brief summation of the really encouraging results that we're using for these triple negative tumors. So these are the hardest tumors for us to treat clinically. We don't have targeted agents for them, but the use of Keytruda is really increasing our responses. So what we call a pathologic complete response means we treat them with chemotherapy, I do their surgery, I call them at home, and there's 0 cancer cells left. And that's my favorite phone call that I make is I call someone after they've gone through 5 months of chemotherapy, and then I can tell them at work there was not a single cell left. So that has increased. So what we call the complete pathologic response rate has increased with Keytruda. They are living longer without any types of recurrences. There is a little bit more side effects, about 4% in this chart here, but for the most part, I would say we're very, very encouraged with the use of this drug in increasing our responses for triple negative tumors. Let's talk about some changes with radiation therapy briefly. There are a lot of options for radiation therapy that didn't exist, and that's changed greatly over my practice in the last 17 years. Traditionally, radiation was given in 33 fractions or 33 days, so that was 6.5 weeks of radiation therapy to the whole breast. You would have to go to the radiation facility once a day, Monday through Friday, for 6.5 weeks. It was very cumbersome to women. Partial breast radiation just radiates around the cavity where the tumor used to live, and that could be given in a faster course, so sometimes 5 days, but it would just target the area right around the breast tissue. All of the radiation plans that we do are 3-dimensionally planned with physicists. Everyone has concerns about their heart and lungs, and if you look at the bottom left, there's an example of what we call deep breath hold. So you have a patient take a big inhalation and hold their breath, and that moves the heart out of the way. So in women, especially with left-sided tumors, we have lots of safety things available to us to make sure we're not radiating any other tissues that shouldn't be seeing any kind of radiation dose. But what radiation does is go through and it sterilizes what's not removed from the surgery and lowers our chance of local recurrence. We now have options that are 5 days of treatment instead of 33 days of treatment. That can be a partial breast course or a whole breast course given in 5 days. So it's much more convenient than it used to be. Brief touch on regional anesthetics. We've learned, you can go ahead to the next slide. You can go ahead just and fast forward through all these. Certainly, we know that surgery is a stressful time for people, the bleeding, the dysregulation in temperature and stress hormones and all of these things. They are doing anesthetic research to figure out which drugs are better for breast cancer outcomes. And it's interesting that they're showing that some of these drugs actually might have better cancer outcomes. So these are kind of listed here as we're going to use some of the drugs more often and avoid other drugs to optimize not just your anesthetic, but also potentially your cancer outcome. We're also using a lot of regional blocks for our mastectomies and reconstruction, and which has allowed us to do almost all of our breast surgery outpatient. And this talks about propofol and lowering the amount of immunosuppression. So again, more studies on how anesthetics can impact cancer outcomes. I think that's all I have for slides. Pardon the little technical glitches, but I can take questions.
Yes, thank you so much, Dr. Caughran. That was wonderful. Thank you. We do have a few questions that have been submitted. So if you're ready, we can just start right into those.
Yeah.
The first one is, what should someone expect during a biopsy?
So most or almost all breast biopsies should be done with a needle. And so really we have to use whatever technology we had to detect the lesion to guide the biopsy. So if it's a solid mass or something we can see on ultrasound, we're always going to do an ultrasound guided biopsy. So the technician will bring you back, they'll find the area with an ultrasound, they'll numb up the tissue from your skin down to the lesion, and then the radiologist will sample the area several times with a large core biopsy needle. So that will give us all of the architecture of the lesion. So we can send a big, healthy piece of that lesion to the pathologist so they can tell us everything we need to know about whatever that mass is. Similarly, if it's something that we see only on a mammogram, like calcifications, we would have to use the mammogram to do the biopsy. That's called a stereotactic biopsy. There's two ways to do that. One is seated in a chair, and they would put you in compression like a mammogram and then sample the area using the mammogram guidance. We don't do ours seated. We have patients lay on their stomach for those biopsies because if they get lightheaded, they're laying on their stomach and they're not going to fall backwards while they're seated in a chair. So we do our stereotactic biopsies or mammogram guided biopsies on people's stomachs. Again, same kind of thing. They'll find the lesion using the mammogram, numb up the skin, and then sample it with a needle. We do MRI guided biopsies. So same thing in the MRI machine, you'll be on your stomach. They use a grid up against the breast and they can find the area using the grid kind of like Battleship to sample it. Again, with numbing medication, local anesthetic, you can drive yourself. And I was going to mention it earlier, I didn't talk about it. Contrast enhanced mammography, one of the problems we had with that is that we didn't have a biopsy technique to target something. So if we can only see it on a contrasted mammogram, we didn't have a way of sampling it, but now there's an add-on to the machine that we can now do biopsies with that.
Thank you. And I think you may have mentioned it earlier in the presentation, but could you quickly touch on how quickly someone would usually get results, and if there's somebody that kind of walks them through that process of what to expect?
Yep. So all of our breast biopsies, we have 2 benign breast navigators on the imaging side of our department. So when you come for your biopsy, you'll meet with one of the nurses. They'll go through your contact information, the aftercare instructions with you. We always ask patients if they want to find out their biopsy results in person or by phone as soon as we receive them. In current modern day world, everything is released into the chart immediately so people can read their own results, and that's just the life, the world we live in now. But what will happen is if we get a malignant result or a high-risk result that would require some kind of consultation with the surgeon, our navigators will find those appointments prior to even calling you so that when they call you, they will tell you what we understand about the biopsy, what we know so far, and then they will give you choices of when your appointments can be. We want to have needle biopsy results within 48 hours. It's usually a little bit faster than that. And then our rules in our office is if you have a malignant result, you have to see a surgeon within 5 days. So you're not going to go more than a week without meeting with one of us to talk about what your cancer plan is going to be. So that is an automated process in our center. Any type of biopsy is going to be managed by our navigators. You'll have their contact information. They will be calling you, and we will have appointments set up for you within 5 days.
Thank you very much. The next couple of questions are related to screening. The first one is, can you remind us again what the recommended screenings are for regular risk patients?
Depends on who you ask. I like the rule every year starting at 40. So it's hard for us to stratify risk for patients for a whole population. And what I tell patients is I don't feel comfortable going every other year until I can predict who's going to grow an aggressive cancer or not. So interval cancers happen. You have a normal mammogram one year, and then something can happen in 6 months and you feel something. That doesn't mean you're fine. It means we need to check you. So I still believe personally that we should go every year starting at 40. There's definitely more impact on screening the population under 50 going every year, and that's why they talk about the option of going every other year after age 50. The way that I look at it and why we talked about mammogram compliance is that even in a very well-intentioned patient population, we sometimes get late and we sometimes miss them, and life happens and we get delayed. And so I think the more we confuse patients and the more we tell them they can go 2 years or whatever, it gets lost and it doesn't become routine. So every once in a while, I get a super compliant patient that is like Johnny on the spot that has them to the day every single year. And I love that and I high five them. But most women have some delays in their care, and myself included, that you just schedule it the next month and then it starts getting bumped out. So I still believe every year at 40 is my role.
Thank you very much. Would those be the same guidelines for someone with dense breast, or would they need more frequent screening?
No, so doing the same test more often doesn't help you. So at minimum, all women mammogram once a year, 3D mammogram for sure if you have dense breasts. All of our machines are 3D at Trinity, so that's not a concern. If we want to add anything to that screening, the next best test that we would use for screening is MRI, and that can be done if you're high risk through your insurance, or if you are not high risk as a cash pay option. But that's why, again, self breast exams are important, and I do want women to check themselves once a month or get to know their normal is the term that we use.
Thank you. The next question, I believe, is referencing a slide that you had shared regarding risk factors, and
Mm-hmm.
it mentioned a risk percentage. How do you know what your risk is?
Oh, it's a great question. There are multiple different risk calculators that we use, and some of them are weighted on family history. Some of them are weighted on your estrogen exposure, Gale risk, Klaus risk, BRCA-Pro. There's all these different risk models that we use. In our comprehensive breast center, we have a very extensive high risk software program. So if you come to have a risk assessment with one of our providers in our office, we will run all of the risk models on you. So we will ask you this extended family history. How many aunts and uncles do you have? How many of them had cancer? How old were they? And it takes all that data and will give us a range of risks using all these different predictive models. We have what we call a Mammo Plus program. So it's our mammogram plus a screening. So every screening mammogram we do at Trinity has a Gale risk associated with that, which is a good population-based risk assessment that we do on every single mammogram that's unique to us. We will be expanding that in the future, I believe, with adding in additional risk calculations with our screening mammogram population. So when you come, if your technician says, hey, you are scoring in a high risk range, would you like to make an appointment to have a full risk assessment done? Then we can really dial down and say, okay, this is your breast density. This is how old you were when you started your period. This is your family history. This is your biopsy history. And we'll talk about the ranges of risk that you're in and then customize your screening for you. There's also things that we can do like risk reducing medications, which are pills that you would take once a day for 5 years that could cut your risk of breast cancer in half. So lots of options that we have in the high risk program.
Thank you very much. The next question is asking about the breast MRI, the out of pocket cost.
Yep.
That one, it is asking if those are available at all of the same locations that the 3D mammography screenings are at.
Oh, I wish. No, there's only a handful of breast MRI coils. So that would be at the downtown Grand Rapids location.
Thank you very much. The next question is asking if you could share which office you are at.
So I'm at the Lax Cancer Center in Grand Rapids
Thank you
at the
very much.
Comprehensive Breast Center there. So it's my clinical practice is connected to that breast imaging center.
Perfect. Thank you so much. The next one is asking if you are having a yearly breast MRI due to genetic mutation, are there any long-term effects from having the IV with contrast?
Very good question, and I'm glad I spoke to my breast imager not too long ago about this very thing. Gadolinium is the contrast that we use to do breast MRIs, and there was some concern initially that gadolinium could be deposited in the brain tissue and maybe have some long-term effects on the brain, and that has recently been debunked. So that is not a long-term risk factor anymore that we're concerned about. But no, there's no radiation to an MRI, so the biggest risk is getting an IV and having to hold still for 45 minutes.
Thank you so much.
Mhm.
Next one is, what risk factor do you think an ATM gene mutation has?
It's a good question, and it's really based on the family history and the age of the patient. So that asktome.org website that we talked about, we could customize it for the patient based on their age and that ATM mutation. I didn't include the slide in this PowerPoint, but I can send one to that patient or question whoever is asking that question, that we can customize the ATM risks, and it kind of puts it in perspective with the other risk factors. But that's one of the ones that we see in our office and we manage risk for.
Wonderful. I can get that patient email or that person's
Mhm.
email and get that for you. The next question is asking if, going back to risk factors, is there one of the risk factors that you feel outweighs or has more weight than other risk factors?
Well, the most common are, and again, nobody likes to hear it, the fact that we're women, we have more breast tissue, and we're all aging. So the ones that we can't modify are female sex and aging. Other than that, the other one that really jumps up on the risk factor are the atypical biopsies. So if you've had a needle biopsy for calcifications, for example, and it showed atypical cells, that's going to put you in a much higher risk factor than the average population patient. And those patients should be followed in our high risk clinic for closer monitoring. Other than that, it would be the genetic mutation patients. So making sure we're testing the appropriate people. Genetic testing, luckily, is a lot easier to do than it used to be. It used to be about a $4,000 test, and now it's about $280. So it's a lot easier to get it covered by insurance. And if it isn't covered by insurance, it's much more manageable to pay for out of pocket.
Thank you. Are there any lifestyle changes that could be made to reduce an overall risk?
Yeah, I wish there was something magical that I could say if we all ate grapefruit and we never had sugar, it would all go away. It's just not that simple. The study for diet is very mixed in breast cancer. Some diet studies have shown improvement with low fat diet versus high fruits and vegetable diet. Making sure you have enough folate in your diet, not smoking, even though that's not a specific thing for breast cancer, that's definitely a risk factor for other cancers. Um, I say in general, it's a common sense diet. Eat a lot of fruits and vegetables and don't cover them in butter and cheeses. You know, eat more vegetables than you're eating fatty meats, for example, and um, small amounts of cheese or high fat foods probably should be done and limited to, moderate amounts. But the main thing for women is like being heart healthy. So exercising, not gaining weight, especially postmenopausally, those are things that are linked to breast cancer. So doing things that make sense for your heart probably makes sense for breast cancer risk too.
And I think that that was, in fact, our last one. So thank you so much for all of
Thank you.
your presentation and all of those great answers. We really appreciate it. And thank you to everybody that joined us this evening.
All right. Thanks. Have a good night.